My name is Andreas Fritzen, and I'm a postdoc in the Molecular Physiology group at the Department of Nutrition, Exercise and Sports at University of Copenhagen. And I'm very honored on behalf of the Danish Diabetes Academy to present one of the greatest exercise physiologists on the Southern Hemisphere, Professor Glenn McConell. Glenn McConell is a professor of exercise metabolism at Victoria University in Melbourne, Australia. And he has more than 30 years experience in exercise metabolism research and is internationally recognized in regard to the regulation of skeletal muscle glucose uptake with exercise. His research focuses on glucose metabolism, including examining the factors regulating skeletal muscle glucose uptake during exercise and also the increase in insulin sensitivity after exercise. He has also been whether exercise early in life can prevent the insulin resistance associated with being born small for gestational age or having an obese father, and has begun lately examining whether exercise can overcome the insulin resistance caused by shift work. We have been so fortunate to have Professor McConell as a DDA-sponsored visiting professor in our section, and we have learned a lot from him. And I hope we all learn a lot today when Glenn will be presenting his very exciting and provocative data. So, please, Glenn, go ahead.
Thank you very much, Andreas. I've very much enjoyed, as you said, visiting you guys, and I'll be presenting some of that data today. Thank you, Honey, as well, for organizing this. Great job. And I also wanted to mention, of course, the Danish Diabetes Academy for granting me a visiting professorship, especially Tor Christensen. So the Danish Diabetes Academy, obviously sponsored by Novo Nordisk, has given me great opportunities. I've been out to Copenhagen now 3 times, and once was in 2019, just before COVID, and they've actually said I have funding to go back in 2022 after COVID. So it's nice of them to organize things around COVID for me. Obviously, just joking. It's not a joking matter. So, okay, we'll go to the first slide. So thank you again. As you said, this talk is going to be a little bit provocative here. So talking about, is it time to question euglycemic hyperinsulinic clamps for muscle insulin sensitivity? All right, so just an overview discussing euglycemic hyperinsulinic clamps. What are they and how they're used for insulin sensitivity. Talking about how exercise, so as Andreas obviously made clear, I'm an exercise guy, so mainly going to be talking about the clamps in response to exercise, so the increase in insulin sensitivity, which is observed after exercise. The fact that exercise does increase insulin sensitivity, and then talking about how does exercise increase insulin sensitivity. And this is the thing with working with Erik Richter in particular, and other people at the University of Copenhagen. I think I'd like to think we've made some real advances on that in the last few years with Jan Wojciechowski, Bente Keynes, a whole bunch of people there. And then we've started to think about the role of the interstitium, which, as you'll see, we tend to not really think about a whole bunch with glucose uptake. We tend to assume everything just passes straight through and it's not really doing a whole lot. And then this is where things start to get a bit provocative. Start thinking about the results that we get when we look at clamps versus meals. And is the clamp actually the best way to really look at insulin sensitivity? And then, so now what? All right, so where do we go from here? So first of all, what is the euglycemic hyperinsulinic clamp? All right, so euglycemia obviously means normal glucose and high insulin. All right, now, I don't know how easy this works. I was going to see, I'm more used to Zoom. I was going to get people to put their hands up. Maybe we'll just skip over this bit a little bit. So I was wondering how many of you have actually run a clamp. I know a lot of us have been involved with clamps, but actually been there saying, okay, should we increase the glucose infusion rate, slow it down? What do we do next? Taking the samples every 5 to 7 minutes or so. Probably quite a few, but I'm assuming quite a lot of have probably not done that either. So how it works is, as I said, it is the gold standard for assessing insulin sensitivity. It's used in human studies, rodent studies, etc. So what you do is you infuse insulin you do a bolus and then you infuse it at a constant rate to result in hyperinsulinemia. Okay, so high insulin, and it's fair to say that it's probably a little bit above the physiological, so slightly, a little bit above that, and we'll go through that a little bit later. And then naturally that insulin, that high insulin, is going to stimulate glucose uptake by the tissues. So what happens is if the glucose is taken up at a high rate, you then have to infuse the glucose at a higher rate to keep it at a normal level. Right, so step back a bit. The insulin's elevated, stimulates glucose uptake, so the glucose will start to drop. You infuse the glucose at a variable rate to keep the glucose at a normal level. And naturally, if you look at that rate of glucose infusion, right, you get an idea of the insulin sensitivity. So if you have high insulin sensitivity, your glucose infusion rate will be high. If it's low, it'll be low, right? So obviously people with type 2 diabetes tend to have a low glucose infusion rate. Now, but often people use the glucose infusion rate as insulin sensitivity, but really it should be the glucose infusion rate divided by the insulin concentration. That gives you the insulin sensitivity, okay? But, you know, the insulin's usually high and pretty constant, so it's the same sort of thing. So, as I said, if we look at insulin sensitivity and we compare people with type 2 diabetes to control people that don't have diabetes, and we look at that glucose infusion rate during a hyperinsulinic glycemic clamp, you can see that it's naturally higher in the people that don't have diabetes than the people that do have diabetes, okay? So that's pretty clear, and that's been going on for years. DeFronzo was, you know, the one that sort of came up with this. And interestingly, you can see here that the glucose infusion rate, the reason it's lower in the people with type 2 diabetes, I'm not saying it's the cause, I'm not saying it's the first thing that goes wrong. I'm just saying when you look at the bulk of the glucose uptake is by muscle, and the main problem in the people with diabetes is that the muscle is not clearing it as quickly, okay? I'm not saying it's the cause, I'm not saying it's the first thing. I'm just saying in terms of where does the glucose go, it's mainly into the muscle in all of us, and it's mainly into the muscle in the people with diabetes, and their main defect is at the level of the muscle. Okay, so during a clamp, you usually increase the insulin by about 100 microinternational units per mil, and I'll get back to that later, okay? So that's a clamp. Now, exercise increases insulin sensitivities, all right? So this is showing 8 weeks of exercise, so a classic study from John Hawley's lab with Clinton Bruce during his PhD. You can see here the glucose infusion rate in people with type 2 diabetes versus controls before, so pre and post 8 weeks of exercise training. So there's a few things going on here. First of all, you can see, you know, just like the previous slide showed, the glucose infusion rate is much lower in the people with type 2 diabetes, even more so in this study than the controls. But you can also see the exercise training for 8 weeks increased the insulin sensitivity in both groups. There was a main effect, but, you know, you can see that it's still, even after the exercise training, it is much, much lower in the people with type 2 diabetes. So that's why, as we all probably know, we try to prevent the diabetes, right? Rather than try and, overcome it. So, you can improve it by the exercise, but obviously be much better to try and prevent it. So we know exercise improves insulin sensitivity. Now, this is 8 weeks of exercise training. Now, what about an acute bout? And more now, we tend to see that the responses to training are like the responses to a series of acute bouts, right? So sometimes we look at what happens with one bout to then try and see what's happening with exercise. Now, so we go, how does exercise increase insulin sensitivity, right? Now, I went a bit ahead of myself there. So you can see that exercise increases insulin sensitivity. Now you say, how does it increase insulin sensitivity, right? Now, what we tend to often think about is weight loss, all right? Now, but this study and quite a few others have shown that, a short period of exercise training, a few weeks, up to 8 to 12 weeks or so, you often don't get a change in body weight because the person tends to just eat more to make up for the energy expenditure. So you can see that you can get an improvement in insulin sensitivity independent of weight loss, right? So that's really quite remarkable. So I always try and point that out to diabetes doctors and diabetes educators and people with diabetes, that the exercise itself can improve insulin sensitivity. Obviously, I'm not saying don't worry about weight loss. Weight loss is incredibly important, but it's just that the exercise has its own effects, right? Now, this is where I wanted to say that exercise, each bout, has acute effects which kind of add together to cause the effects of training. So what we've been looking at more recently is the effect of one bout of exercise. And you can see here, I mean, I've been looking at it recently with Eric Richter and Jan Wojciechowski and others, but they showed back in the year 2000 that if you do 1 hour of exercise, this is leg kicking, I'll show you this in a bit, and then you wait 4 hours, so for those acute effects of exercise to drop off so that the glucose clearance, the glucose uptake, the blood flow are pretty much back to normal, and then you do the clamp, right, so the euglycemic hyperinsulinic clamp, you see that there is naturally an increase in glucose uptake, right, but you've got a rested leg and an exercise leg. So you can see that the glucose uptake and glucose clearance is greatly increased with the insulin infusion in the rested leg, but you can see the remarkably greater increase in insulin clearance, uptake, disposal, etc., with the previous exercise. Right, so that's been known since then, but we've been a lot of work going on, largely again in Copenhagen, trying to work out the mechanisms. So, you know, when I started, when we did the first study a few years ago with Eric and Jan, it wasn't that clear what was happening with insulin signaling. It looked like it was no different in the two legs. And also we didn't know what happened with blood flow. So what we did first of all is, because I'd done a lot of stuff with nitric oxide synthase inhibition, so NOS inhibition, looking at glucose uptake during exercise. And we'd started to look a little bit after exercise with my studies. I said, why don't we look at what's happening with whether blood flow is important? So we came over and we did a study where we did the one-legged kicking exercise. So you can see here, all right, so really nice little model here. Where you can do the one-legged kicking, so that you've got the whole body, the whole body's involved. You've got a rested leg, exercise leg. So therefore, when you come along 4 hours later and infuse do the clamp, you know, you've got the same glucose and insulin levels in the whole body, the same hormones, the same everything, but one leg is rested and one is exercised. So we did muscle biopsies to look at insulin signaling. We also infused microbubbles, which I'll expand on in a moment, to look at microvascular blood flow in the muscle. And then, as I said, I've done a lot of stuff with nitric oxide synthase. So we gave a nitric oxide synthase inhibitor, LNMMA, to reduce the blood flow and see what effect that had on the insulin sensitivity. So here's that same chap I showed before. So it is a bit of an eyeful here. You can see he's got 7 catheters in him. So femoral artery and femoral vein of the exercise leg and the rested leg. We're also infusing glucose and insulin whole body. We're measuring blood samples from a heated hand, and we were infusing these microbubbles to perform contrast-enhanced ultrasound. So I was saying Kim here was the expert in the lab there for doing that microbubble measurements, and Eric Richter is my main man there. It's been great, these 3 visits I've had there. So, you know, he does the muscle biopsies and runs the clamps and things. And the difference we did was the NOS inhibitor that we infused into both femoral arteries. And that's why we had to take the glucose samples from the hand, because we had the NOS inhibitors going in, etc. And we had biopsies to measure insulin signaling. And then you infuse the microbubbles, and then you hit them with the ultrasound, which is what Kim did. That blows up the microbubbles. And then you can see the microbubbles coming back in, and you can work out microvascular blood flow. So that hadn't been looked at previously in terms of the effect of acute exercise. So what we can see here, it's quite a busy slide, but you can see here's the nice arterial glucose concentrations, nicely clamped there throughout the insulin infusion, the clamp. And you can see here that the glucose infusion rate obviously goes up, but you don't know what's happening in each leg. So then you look down here and say, okay, what's happening with leg glucose uptake? So as we'd know from previous studies, you get a nice increase in glucose uptake in the rested leg. It's greater than in the exercise leg. And then when we gave the NOS inhibitor LNMMA, you see the glucose uptake came down, and it was not actually different to the rested leg. Now, naturally, the NOS inhibitor caused a reduction in blood flow. And even though the arterial venous difference went up to try and extract more glucose, it wasn't able to compensate. So the glucose uptake dropped. Now, as I said, we also were able to measure. So what we've got is AV balance across the leg. So you get the glucose coming in, the glucose going out, and then you look at that difference and multiply it by the blood flow, and you get the leg glucose uptake. And if we look at the actual blood flow through the muscle itself, right, not just the leg blood flow that we measured up higher, you can see here that the microvascular blood flow, or also sometimes called the capillary blood flow, because it really is in there at the capillary level, you see that it's essentially the same at rest in the basal situation, 4 hours after exercise, in the rested and exercise leg. There's a tendency that it was a bit higher in the exercise leg. But then when we gave the insulin, you can see a big increase in blood flow, especially in the exercise leg, right? And then when you give the NOS inhibitor, it came down, right? So you might say, okay, the increase in glucose uptake is probably because of the blood flow, because you get a big increase in blood flow, and then when you inhibit it, the blood flow comes down. But we did actually, and thanks again to Jan Wojciechowski's group, they'd come up in collaboration with Jonas Chebek with a TBC1D4, which is also called AS160, a site at 704, which you could see was exercise responsive. Right? So unlike AKT, which goes up the same in both legs, so here's rest, and then insulin, the rested leg and exercise leg go up the same. You can see there was an exercise effect here, that it went up more at rest and then was higher with the insulin in the previously exercise leg. So what we think is going on is that during a clamp, 4 hours after exercise, you get an increase in microvascular blood flow. So you get increased glucose delivery, as we showed. You get an increase in insulin signaling, as I showed here with the 704 site. So TBC1D4, increase in insulin signaling. Therefore, you get more GLUT4 on the membrane, which we've actually shown more recently. And therefore, you get a nice glucose uptake, right? And then we think when you give the NOS inhibitor, you drop the blood flow. You don't actually affect the insulin signaling. That stayed up. So you see the insulin signaling was not affected by the NOS inhibitor. So what happens is you get the NOS inhibitor drops the flow, and then the glucose uptake drops, okay? And this is when we started thinking about the interstitium. We said, hang on a minute, if the NOS inhibitor reduces the glucose uptake, but it's not affecting insulin signaling, then you've probably still got lots of GLUT4 on the membrane, right? But you haven't got the blood flow because you've given the NOS inhibitor. So I wonder what happens to the interstitium, right? So we started thinking about that, and that was what we did in my last visit in 2019 for 6 months, which was fantastic. I love preaching to the converter with you guys. Love Denmark, love Copenhagen, love riding bikes everywhere. Love it, love it, love it. Okay, so anyway, it's great. All right, so we came back and we said, let's look at the interstitium. And this was specifically funded by the Danish Diabetes Academy visiting professorship. So we said, what's happening here to the interstitium? Because if you're getting a drop in the glucose delivery, but the insulin signaling is still up, then if the interstitial glucose drops because the muscle is taking up all this glucose, but there's not been much glucose delivery, this interstitium might drop, and therefore you're messing up the glucose gradient. Because remember, GLUT4 is facilitated diffusion, so you need that concentration gradient and you need the GLUT4 on the membrane. Right, so that's what we looked at. So purposely had Frederick Goetz pop up there. He was a great help. So when I came over for 6 months, we spent the first 3 months, Frederick and I, pretty much trying to work out how to do microdialysis in humans. So we could put the microdialysis probes right deep into the muscle. All right, so you put the microdialysis probes right into the muscle, about the same depth as the biopsies, and you could measure the interstitial glucose in the muscle. All right, so thank you, Frederick, for that. Lots of mucking around with beakers full of glucose and labeled glucose and things like that. So an hour of exercise, same protocol again as before, except we had the microdialysis probes in, did microdialysis, and we did the clamps, everything the same pretty much, okay? We also did ATP, but I won't really go into that, NOS inhibition and ATP. So what the idea of the microdialysis is you're perfusing a solution of glucose that contains radioactive glucose. So you've got black as the normal glucose, the blue is the tracer, and then it equilibrates, and then you measure what comes out, right? So you look at the glucose concentration, and the tritiated glucose specific activity, and you get an idea of the interstitial glucose. Obviously, it's not perfect. You're definitely doing damage to the muscle, but the assumption is that is the interstitial glucose. Now, this very attractive young leg, you can see the old elasticity issues there is my old leg. All right, so what did we find? So remember, this is the same protocol as what we did previously. An hour of exercise with one leg, 4 hours rest, and then we do the clamp. All right, and look what happens. We were amazed, and we repeated it over and over and said, what is going on here? And at one stage we thought it was voodoo, but in the end, we actually think we know what's going on. So you see, here's the arterial glucose, so well clamped. Here's the resting leg. You can see even before the NOS inhibitor. So just when you give the insulin, the interstitial glucose drops a lot, but it drops even more in the previously exercised leg. And naturally, when you give the NOS inhibitor, it drops more even so. But we were particularly surprised by the massive drops. So you're talking about dropping from 5 to 3 here and 2.3 at the end of that. Okay, so remarkable drops in interstitial glucose. Now, we started thinking about, well, what's going on there, all right? So we started thinking, I'll just skip for a minute. Hang on, this is a clamp, right? So the interstitial glucose is dropping like crazy. And then we're assuming this is what would happen in normal physiology, like the same when you have a meal. But then we started thinking, well, hang on a minute. When you do a clamp, you're clamping the glucose delivery at 5 millimole, right? So, I've shown you that earlier and showing you again, or whatever you've clamped it at. So here, 5.5. So you're not actually getting much of an increase in glucose delivery, but you're getting a massive increase in insulin signaling and GLUT4 on the membrane, massive increases. So we thought maybe the interstitial glucose drops because you're actually clamping the glucose. So even though you get an increase in vascular blood flow, you're not getting enough glucose delivery, so the interstitial glucose drops like crazy, right? So we thought, well, how do we test that, right? So because is a clamp real life, right? A clamp is not necessarily real life. So if we think about a clamp compared to when you have a meal, you have no increase in glucose concentration, which you do with a meal. Insulin is fixed and elevated above physiological. Insulin tends to be pulsatile, but here it's fixed. You're obviously bypassing the pancreatic function. You're not worrying about the gut. You're not worrying about mouth receptors, that are involved in releasing all sorts of things. And you're bypassing the incretins, the GLP-1 and things like that. So, infusing glucose and insulin straight into the arm is not really particularly physiological. So what we started thinking about is, what about if you had a meal? Do you get the drop in interstitial glucose still? And, are you able to maintain it? Because you're actually increasing the glucose concentration. So maybe it's a very different situation. So I've pretty much gone through all that. So you can see when you do a clamp, the glucose drops like crazy. What about a meal? Okay. So we did exactly the same thing again with the microdialysis, the exercise, the 4 hours of this time it's 3 hours recovery. We put in the microdialysis probes, but this time we had meals, right, instead of clamp. And here you can see a very different situation. Here the glucose, instead of being clamped, goes up. So here's the arterial glucose, goes up after the meals, obviously. And the interstitial glucose in the muscle, there's a bit of a delay, of course, but the interstitial glucose goes up as well. So very different to what we saw with the clamp, okay? And you get really big increases in glucose uptake and muscle permeability to glucose, which is synonymous with GLUT4. Massive increases in muscle permeability to glucose and massive increases in glucose uptake. So if you actually look at the clamp, this is the glucose uptake per unit of lean muscle with a clamp. So if we look after 45 minutes, say it's 100, gets up to 150. If you look after 45 minutes here, it's 200 with a meal, all right? So it's actually a lot higher. I know the scale isn't particularly helpful, but if you look here, it's 150 there. This is like 220. So it's a lot higher with the meal, despite, if anything, lower insulin. So I'll show you that here. So, it may be something like GLP that's playing a role. So if you look at the insulin here, this is the insulin from the first, we've only done a few subjects, but you can see here's the insulin with the meals, goes up to about 80 or so. But in the 2 clamp studies that I was involved in with Eric and Kim Sherberg, you can see that the insulin went from 4 to 103 or 6 to 108. So if anything, it's obviously more like 80 instead of 103 or 108. So you've got lower insulin, if anything, but much higher glucose uptake, right? So I think it makes sense because unlike what happens with the clamp, when the interstitial glucose drops like crazy, we see with the meal, you get an increase in blood flow in the leg, you get an increase in blood glucose concentration, you therefore get an increase in glucose in the interstitium, and therefore you get a greater gradient for glucose uptake. And we measured again, you get the nice big increase in GLUT4 on the membrane. Well, we measured the permeability to glucose. So you've got happy days. Like, this is not an intelligent design, is it? Why would you have a situation where blood flow is higher, GLUT4 on the membrane is higher, insulin signaling is higher, but interstitial glucose drops? This makes a lot more sense, and this is what happens physiologically after a meal. Okay, so now what? So just finishing up. So what do? We keep doing clamps. Yep, I'm not suggesting we forget about clamps. It is the gold standard. I'm just saying maybe we need to think about it a bit more. Maybe we need to do hyperinsulinic, hyperglycemic clamps, all right? So I know some people have done these in the past. So instead of clamping the glucose, maybe you've got to think about the glucose concentration as well. You can do clamps with traces, which is another thing, but that's mainly really just giving you an idea of what's happening to hepatic insulin sensitivity. There's other things, obviously, more simple things like IV GDT. Intravenous glucose tolerance test is still bypassing the gut because you infuse the glucose straight into an antecubital vein usually. Oral glucose tolerance test obviously is used a lot. I don't want to give this a hard time, but recently Michelle Kesky showed that unlike a meal, which increases muscle capillary blood flow, oral glucose tolerance tests actually reduce muscle capillary blood flow. So it might be, again, because it's not physiological. We don't usually have 75 grams of dextrose in a meal, right? We have a mixed meal. So therefore, maybe meal tolerance tests are getting closer. And I would suggest the other thing you can do is meals with triple traces. It's another discussion. I would suggest just continuous glucose monitoring is a good way of seeing what's happening, you know, and very simple, very cheap, and gives you an idea. So unlike you know, complicated studies, sometimes there's been studies which have shown that a bout of exercise doesn't increase whole body insulin sensitivity using a clamp. But if you just do continuous glucose monitoring, you find consistently that here's people with type 2 diabetes after a bout of high intensity interval training, and you follow them for the next day, and you find that here's the glucose concentration when they have meals and things, and sleeping and meals. In the control, people that with type 2 diabetes, and here is when they did the exercise, and you can see that it's significantly lower, all right? So maybe that's just a good way to see, are the people with diabetes actually more insulin sensitive? So thank you very much for your time. I'd like to acknowledge, of course, the Danish Diabetes Academy for their support of me for my visits. And, you know, I've got funding to come again, as I said, which is fantastic. I'd like to thank everyone at University of Copenhagen, especially Eric, Richter, Kim, Frederick, as I mentioned, Jon Wojciechowski, and everyone else that's helped out there. And these are all my other sort of collaborators that got me to that point with the NOS inhibition and all that sort of stuff. So thank you very much for your time.
Thank you so much. A very great presentation. I learned a lot, at least. And now time for all of you to ask questions. Let's have a great discussion with Glenn and discuss these thought-provoking data. Until you have done that, I can maybe give you come with the first question. Glenn, so is this mainly a thing after exercise? So in the rested leg, you also see a lowering of blood glucose, but within 1.5 hours, maybe only 1 millimolar or something like that? Would you?
Yes.
Would you be similarly concerned during it just in, I mean, we have a lot of diabetes researchers here not doing the exercise thing.
Yes. I think,
also,
yeah, exactly. Yeah, I think it is something to consider. I mean, you know, like you said, even in the rested leg, if I could actually find it, there was a reduction in the glucose, but yeah, it wasn't as much. But it is an interesting concept though to think about, right? I've actually been trying to get funding. As a guy here, Neil Cohen from the Baker Institute, we've been saying that they may have to think about people with type 1 diabetes as well, because they are insulin resistant. They have very high levels of insulin that they are sitting at all the time, and we try and get their glucose down as low as possible. So I wouldn't be surprised if their leg, I've tried to get funding for this, but no luck so far. I think they're walking around like they were just a clamp the whole time. Really high insulin. We try and have their glucose as normal as possible. I wouldn't be surprised if their interstitial glucose in the muscle was low, but we haven't looked at that.
Great, thanks. And we have the first question, a brave one. Thanks. Janne Hingst, would you bring up your question? Or I can out loud. So Janne writes, response / increase in the exercise leg. Maybe, is it more common, Janne?
Sorry?
Yeah,
maybe the person could unmute even, maybe, if they want.
Janne is not able to answer your question, Andreas.
Okay, sorry. So, oh yes, that's right. Okay, until we have the technical things going on, can you meanwhile have Janne unmuted? Then I
can unmute Janne if she.
Yeah.
Janne, you're unmuted. Are you ready to?
Yeah,
speak?
I'm ready. Can you hear me?
Yes.
Yeah. So Glenn, fantastic presentation. So I was wondering, could you comment on why we see a faster increase in leg glucose uptake in the exercise leg?
Why is it more or why is it faster?
No, I mean, if you look at the initial response, it's quite dramatic, the increase in the exercise leg compared to the rested leg.
Yeah.
Yeah,
just the leg glucose uptake itself.
Yes.
Yeah. Not the drop in interstitial or whatever.
No.
Yeah, that's the question that that is something I need to think about more, obviously. I know Eric and I spoke about this at one stage. I mean, it's more sensitive to insulin, right? So it's going to respond. It's going to get a greater increase in insulin signaling, greater increase in blood flow. Why is it quicker initially? This is what you're talking about here.
Yeah.
Why is the slope greater?
Yes.
Yeah, I know what you mean. I mean, I guess it is. I guess I don't know personally the time course. Is the signaling quicker? Is the increase in blood flow quicker? I personally don't know that answer. I think probably someone called E.A. Richter may. But yeah, it's not coming to me right at this millisecond.
But when you look at your membrane permeability, it seems not that you have it fits not with your membrane permeability, right? In the initial response.
Oh, the membrane permeability goes up quickly as well.
Yeah, but is it?
Yeah, just let me jump to that. I have a membrane permeability slide here. Yeah, sorry, I must have deleted it. I had an extra one at the end where I've got with and without NOS inhibition or whatever. But anyway, you're talking about this slide here. Oh yeah, you're talking about the membrane permeability. It's not much different the first 30 minutes.
Correct.
Yeah, I don't know. I'd have to think about that, to be honest.
Okay.
We don't have the microvascular blood flow for this study. The one with the meal, we don't have it for that one. But yeah, I'll just have to think about it. Sorry, mate.
Great. And you should be unmuted now. You have a question?
I've unmuted Eric Richter now.
Oh, okay.
Eric's probably.
Thank you.
You can answer
So I was just commenting. I think the more rapid increase in glucose uptake initially in the exercise leg is a function of the increased microvascular flow, basically delivering more glucose more rapidly and maybe also insulin more rapidly, although we don't really know, but I think that's a logical explanation. But I had a question for you, Glenn. So if you think that
I guess we don't know the time course. Did we look at the time course?
Right.
We can't. The trouble
No.
with the microvascular blood flow, the microbubbles, you can only do like 2 or 3 measurements. Even 3 is pushing it a bit. So you can't really look at the time course. As Eric knows, I'm just more for everybody else. Yes,
Right.
sorry, Eric. Yep.
So if you say that, so I was wondering if the hyperglycemic, hyperinsulinemic clamp is more physiological, which you might say it is because you have the increase in glucose. Why do people then almost always run the euglycemic clamp? Isn't that strange? Or do you see any problems with the hyperglycemic clamp?
Yeah, I know. People have sometimes done the hyperinsulinemic, hyperglycemic clamp. My feeling was that's when they were wanting to know maximum. I think was that when they were trying to make sure they definitely blocked liver glucose output. To be honest, I'm not sure why. I know that sometimes people have done one or the other. I'm not quite sure, and I probably should know why they've done that. I know some people have clamped it at 10 millimole, and just I think they were looking like what was the maximum glucose uptake by muscle when you totally inhibited the liver, or something like that. But it probably just gets a little bit tricky when you have hyperinsulinemia. When you have hyperglycemia, maybe it's going to start stimulating the liver, the pancreas to release insulin, even when you have your hyperinsulinemia. I think that might be the tricky thing because you're obviously trying to give just, exogenous insulin, and you don't really want to be stimulating the pancreas. But when you have high glucose, it may stimulate the pancreas as well. But yeah, I'm not sure.
Yep. Thanks.
Thanks.
Thanks, Eric.
I have a question from DP. He says, great talk. Did someone look at the transition of glucose from the vessel to the interstitium? Is this limiting, apparently?
Yeah. Well, that's actually where Eric Richter wants to probably kick in again. He's been thinking about that, and he had a GLUT1 knockout because GLUT1 is in the endothelium, and he was thinking about glucose maybe being transported through the endothelium. It's always been assumed that it's going through, gaps between the endothelium, but in the brain, at least, there's some evidence that there can be some endothelial transport. Did you want to kick in there again, Eric? I'm totally happy with that. You were looking at that. Is that okay with you, honey?
Eric, you are unmuted now, if you want to speak.
Okay, thank
You
you.
always take it over. I'm happy with that. Yeah.
So, well, the endothelial cells have a lot of GLUT1, and the question is, what is the GLUT1 used for? And we had the idea that maybe some of it is used for transporting glucose across the endothelium. But as Glenn said, it's been known since the 50s that small molecules like glucose and urea can leave the capillaries by just diffusion through the slits, the small pores that are between the endothelial cells. So if GLUT1 participates, it's probably a minor effect. So, but we've looked at it, and I think that the preliminary data suggests that most of the glucose is still coming out of the slits and not through GLUT1. But in the brain, GLUT1 is extremely important. So if you knock out GLUT1 in brain endothelial cells, then the mice are really not doing that well, and they have seizures and so on. So in the brain, it's really critical. In the muscle, I don't think it's critical. But we're not finished yet. We might know later.
Oh, maybe I shouldn't have mentioned that.
No, it's all right.
All right. Yeah, so these slits here. So yeah, it does seem that, when you've got the clamp, you're just not delivering enough glucose to maintain interstitial glucose. It kind of makes sense, right? I mean, it took us a while to actually think about it. And it's like, well, that makes sense in a way. Because even when you give the NOS inhibitor, the signaling stays up, So, all right. So anything
Great.
else?
Then I know Jørgen Wojciechowski has a question. Jørgen, you will be unmuted now, or a comment at least.
Yes, Jørgen, you are unmuted. You can speak if you want to.
Hello, Glenn.
Hi, Jan. How are you?
Thanks. So so I wrote some in the chat. So about the time course. So it's quite interesting because in the good old days we measured the activation of the insulin receptor in the muscle of the two legs, the exercised and the rested leg, and that is fully similar. So both the potency and the time. So that could be a reflection of the arrival of insulin at the surface membrane. So it's not a. I wrote this because you mentioned it could be insulin, or also maybe it was Eric. I don't know, but so I don't think it's insulin delivery that are causing this difference between the two legs. So we did a time course actually I think in that study that you're presenting there with biopsies very early on, after 7 or 10 minutes, 20 minutes, 40 minutes, 60 minutes, and so on. So I don't know what is giving us these differences, but it's not the activation at the cell surface.
Okay, it might be the insulin stimulated blood flow. You know, so Eric mentioned the capillary blood flow. You know, you get the phosphorylation of eNOS, increase in nitric oxide, increases in blood flow. We don't know that time course, but that could be, you know.
Yeah.
The eNOS.
Maybe you're right. Yeah. So I think people have done hyperglycemic claims in the most cases when people have compared euglycemic control subjects with hyperglycemic, for instance,
people with diabetes.
Subjects. And if you don't take away their medications, normally we take away their medication, and therefore they come into the laboratory with hyperglycemia. And then you have two choices: either to clamp them at a hyperglycemia, or you can clamp
bring them down.
Yes.
And that's a tricky one. Yeah. I almost said I gave this a similar talk last week where I had more time, and I talked about some of the pros and cons of clamps and how it's tricky because if you have someone with type 2 diabetes, do you clamp them at where they're at, or do you clamp them, you know, at the same level as the controls? And it becomes hard to compare, right? They also said some other things, which is you can actually manipulate your results with clamps if you know, a bit tricky with how you determine your early infusion rate versus your late infusion rate. And often we have we might do let's get them to 4.8 to 5.2. But if you go, let's put them at 5.2, you can you can crank it up the last 20 minutes or so if you wanted to manipulate it. So I think there's a few things you got to be careful of. But anyway.
Yep. Thanks.
Thank you very much.
Okay, thank you. I just have a small poll that I will open with 2 questions. I hope you will take your time to answer those 2 questions.
Ooh,
and then,
I didn't know you were doing that. I would have sent financial inducements to people. Okay, cool.
I don't think there's any need of that.
No.
Please participate.
Does it come up straight away? Because if so, it might be embarrassing. I don't know.
And sometimes it takes a while for people to type a question in the chat, so we might wait just a minute or 2.
It's giving me the opportunity to answer it, but maybe I won't. The polls come up for me as well. It's a good idea. I do this in my teaching. Yeah.
Can I pose a question?
Yes.
So Glenn, why do you want to use a non-steady state meal test for mechanistic studies rather than a steady state, well-controlled thing on the clamp, using the clamp?
Yeah, of course. I was very aware of that because, you know, obviously when we're talking about a clamp, you know, okay, it depends. It depends, obviously, if you're talking about a mechanistic study or if you want to know is this person with type? So, for example, if you've got people with type 2 diabetes and you put them on a drug and you measure their insulin sensitivity before and after, or you do an exercise training program and you measure them before and after, I personally, after thinking about this and, with our study results and whatever, I would be more interested in their response to just continuous glucose monitoring than to a clamp. I think it gives you a better idea rather than just that snapshot in a relatively non-physiological situation. That's what I was trying to get at. But obviously there are times where you really want to try and control everything and you want to see what's happening to the liver and whatever. I just think we've just got to think about it a little bit more and think, we can't just assume, because what I used to say was, if you ride your bike to work or you go for a run in the morning, it's funny, when I say ride your bike to work in Australia, it's like a big deal. Like not many people do it, but all you guys do it. So it's not a good example. So if you go for a run in the morning and then you have your lunch, you say, my insulin sensitivity is going to be greater in the muscles that I exercised. And you go, well, hang on a minute. This is where I started thinking about it. I said, well, hang on a minute. You don't have a clamp for lunch, right? So you don't really know that. So you've got to actually look at a meal to see what does happen. A clamp is not that physiological, is the point.
No. So a clamp is more a measurement than an intervention. Maybe you could say that, right?
It's more a measurement than a what? Sorry.
Than an intervention like a meal.
Yeah.
So
as you know, though, if you looked at all the classic studies, when you look at Clinton Bruce's study or whatever, when you talk about training increasing insulin sensitivity, it's always a clamp. When you talk about a meal doing a drug having this effect or that effect, metformin, it's always a clamp. I'd be more interested now, to be honest, to see what happens in their 24-hour continuous glucose monitoring. Does it put it down or not? Because I don't think you can necessarily assume it. So, for example, I touched on it, but I didn't have time. But as you know, some studies have shown acute exercise does not increase. You've shown this does not increase insulin sensitivity when you use a clamp and look at whole body. Right? But if you do continuous glucose monitoring, you probably would see it.
Yeah, maybe.
Because you got to admit, it's pretty weird, right? You do exercise, then you do a clamp 4 hours later or the day after, and there's no difference.
But that's at the whole body level.
Exactly.
That's right. And there you have more organs. There you have many organs running. Yeah, I agree.
But if you look at the whole body with the continuous glucose monitoring, you probably would be able to see it. So, yeah. Okay.
Yes, one last question from Alfonso Moreno. Then, what is your favorite method to measure insulin sensitivity? Which one would you recommend?
Well, we were kind of talking about that there. I think it depends on the question. It really depends on the question. I really am at the point now. I mean, I could be wrong, but if I was to design a study now, I wanted to have people with type 2 diabetes and see if training or drug or whatever improve their insulin sensitivity, I'd be interested in following their continuous glucose monitoring. But if I really wanted to look at, what's happening to their insulin signaling, their muscle blood flow or whatever, I would probably do a clamp as well. But, they're kind of two separate things in a way,
And could we get the clamp closer to a meal? Should we co-infuse GLP-1 or incretins or?
Wow.
Could that be an issue?
Yeah, I mean, we kind of vaguely thought about this because I know Kim, I don't know if he's here or not, but he's done some GLP-1 infusions in rodents. And we actually talked about that during the exercise and the clamp with and without GLP-1 infusion. So good thinking there. I think it would be something maybe of interest.
Great.
You might find that the clamp plus the GLP-1 is the same as like a meal, that sort of concept. Yeah.
I don't think I have received any more questions or comments. So I would like to finally thank you, Glenn, for giving this presentation, sharing your work and your data.
Thank you very much.
Of DDA, and thank you so much. So have a nice everyone.
Just to say quickly.
Yeah.
Sorry, just to say quickly, when I teach, I do the polls and the results come out straight away. That's what I was thinking. I was like, oh crap, I don't know if I want to see this. Okay, so thank you very much, everyone. Thanks again to EDA and everyone else, and thanks everyone for your
Thank you, Glenn.
interest.
Thank you. Yes,
Okay,
and thank you all for joining the webinar. Bye bye.